Nerves. Published by WordPress.com. Median nerve entrapment, carpal tunnel syndrome and definition. Median nerve entrapment refers to compression of the median nerve at various sites, leading to sensory and motor deficits. The most common form is carpal tunnel syndrome, CTS, which involves compression of the median nerve at the wrist. Epidemiology. Carpal tunnel syndrome is the most common entrapment neuropathy, typically affecting the wrist, and is often associated with repetitive hand movements or systemic conditions like diabetes. Anatomy of carpal tunnel. Fibroosseous canal, located at the front of the wrist, it transmits flexor tendons from the forearm to the wrist. Boundaries. Floor, proximal carpal row. Roof, transverse carpal ligament. Medial, hook of hamate and pisiform. Lateral, tubercle of scaphoid and crest of trapezium. Contents. Median nerve, tendons of flexor digitorum superficialis, FDS, and profundus, FDP. Flexor pollicis longus, FPL, tendon, radial bursa. Recurrent branch of the deep palmar arch. The flexor carpi radialis, FCR, passes through a special compartment in front of the trapezium. Types of median nerve entrapment. Carpal tunnel syndrome, compression of the median nerve at the wrist. Anterior interosseous nerve, AIN, syndrome. Compression of the AIN at the proximal forearm, affecting motor branches to muscles like the FPL, pronator quadratus, and lateral FDP. Pronator teres syndrome. Compression of the median nerve at the elbow, often seen in well-developed forearm muscles, e.g., weightlifters. Etiology. Anatomic factors. Persistent median artery, hypertrophied lumbricals. Abnormal anatomical sites like the tendinous edge of the deep head of the pronator teres, flexor digitorum superficialis, FDS, arc, bicipital aponeurosis, and accessory head of the FPL. Sites of entrapment. Carpal tunnel, at wrist level. Supracondylar process, rare, in 1% of cases. Ligament of Struthers, between the supracondylar process and the medial epicondyle. Pronator teres, between its two heads. Bicipital aponeurosis. Clinical presentation, C.P. Pain. Nocturnal pain is common for carpal tunnel syndrome, localized at the wrist and lateral 3.5 fingers. Paresthesia. In the palmar aspect of the lateral 3.5 fingers. Preserved sensation in the thenar muscles. Weakness. Motor deficits in the thenar muscles, leading to weak grip. Difficulty making the OK sign due to weakness of FDP and FPL. Provocative tests. Tinel's test. Gentle tapping over the median nerve at the wrist. Fallon test. Wrist flexion for 1 minute. Carpal tunnel compression test, Durkin. Pressure applied to the carpal tunnel for 30 seconds. Semmes-Weinstein test. Used to measure nerve fiber innervation. For pronator teres syndrome, the tests include Tinel sign, over the proximal volar forearm. Resisted elbow flexion and supination, affecting the bicipital aponeurosis. Resisted elbow pronation and extension, affecting the heads of pronator teres. Resisted pip joint flexion, of the middle finger. Differential diagnosis, DD. Pronator teres syndrome, differentiated by passive flexion and extension of the wrist. Carpal tunnel syndrome needs to be distinguished from other conditions like Mannerfeld syndrome, which involves attrition or rupture of the FPL, with tests like passive wrist motion or using a splint above the elbow. Treatment. Conservative. Neutral wrist splinting, particularly for carpal tunnel syndrome. Operative. Carpal tunnel syndrome. Release of the transverse carpal ligament via open or arthroscopic surgery. Decompression. Decompression of affected nerves at their entrapment sites. Complications. Carpal tunnel syndrome. Post-surgical complications include flexor tendon adhesions and recurrence due to inadequate release. Pronator teres syndrome. Complications can include permanent weakness if left untreated or inadequately decompressed.